This 76-year-old patient was referred to me for endodontic treatment of tooth number 19. Crown is old, according to the patient. And according to the patient, everything was fine with the tooth. And then suddenly, about 8 days ago, he started to have a lot of pain, toothache, and tooth became very, very tender and sensitive and painful to biting, chewing on, and also to heat and cold. So he went and saw his dentist, and his dentist referred him to us. So, as you can see, tooth has a crown on it, calcified, so there's no pulp chamber here, as you can see. And as you can see, partially calcified canals. It was very tender to percussion. Palpation was within normal limits. Probings were 2 to 4 millimeters all around. Looks like there's a food pocket here. But patient, remember, this patient is 76 years old, so it seems like he has all his teeth. So we discussed options with the patient, and patient wanted to try to see if tooth could be saved. I told the patient, your tooth, the canals are very calcified, so be prepared to be here for about an hour and 10 minutes with your mouth open. And patient said he was okay with it. He just wanted to save the tooth and get rid of the pain, hopefully. And that's what we did. So let's go ahead and go to the point of view clinical video of this tooth and see how I did this root canal. So topical is administered by my dental assistants. So let's fast forward. So I always give 1 injection of lidocaine with epi, and followed by 1 injection of Marcaine with epi. Marcaine, I like Marcaine because Marcaine is long lasting. So profound anesthesia is maintained for a few hours. Also gives the patient time to go home and start taking their pain medication. So let's fast forward. All right, so lidocaine is in, IA nerve block. Marcaine goes in, inferior alveolar nerve block. So you saw that I got a positive aspiration. I'm moving the needle. Okay, so I was getting too much of the positive aspiration, so I just remove the needle and I'm going to redirect. All right, rubber dam clamp. So we waited about 10 minutes for the local anesthetic to work. So rubber dam clamp, I'm making sure that it locks in and fits properly. Rubber dam, remember, no rubber dam, no root canal. All right, very nice. Tucking in the rubber dam to make sure that we got it nicely sealed. My assistant uses 70% isopropyl alcohol to wipe everything down before we get started. And let's go ahead and go through that crown. I start with a round diamond I don't use water, but I know how to use my high speed and not fry the PDL. I strongly recommend that you use water if you're going through a crown, because it can generate a lot of heat. Again, I have 24 years of experience. I know how to use my high speed without water. So pretend that I'm using water here. Definitely use water. All right, so I went through the porcelain of the PFM crown, and now I'm using a metal cutter, and I'm going through the metal part of the PFM crown. As you can see, I'm brushing. I'm not allowing the burr to stay on the crown for long periods of time, a few seconds each time. That way, very little heat to no heat is generated. But definitely you use water spray. All right. Continue on going through and modifying my endo axis. Remember, we need a straight line endo axis. I don't like these, Instagram clicks and baits, ninja axis and all of that stuff. I don't like those. Those are just for Instagram clicks and baits. I just want to make sure that we don't crack that crown. Sometimes the crown can be saved. Patient doesn't need a new crown necessarily unless he cracks during the endo access, or if, there's decay underneath the crown or the margins are open, then patient will need a new crown. But usually, if all is well and I go through the crown and the crown is fine, then the dentist can just replace my temporary filling with a build-up material of their choosing, which is usually these days composite. Saves the patient a lot of money by not needing a new crown. All right, so let's take a look, and this is what we have so far. Again, endo axis is alive. I call it to be alive. It constantly changes and gets better as I move along the endodontic treatment. Now I'm using an end cutting cylindrical diamond burr. Very carefully in a brushing motion, as you can see under my surgical operating microscope. just brushing away the dentin over these calcified canal orifices. Remember, there's no pulp chamber. So don't be expecting your bird to fall right into a really nice and deep pulp chamber. Nope, that's not gonna happen here. So you need to be really careful. We don't wanna remove too much dentin. And also, to the new dentists, these types of root canals, before you know it, you've perforated. So you need to be very careful. I strongly recommend, if you're a general dentist and don't have much experience doing these types of root canals, refer these cases out. Do the ones that you're comfortable with. Refer these tough cases out. So this is what we have so far. All right. All right, so switching to my ultrasonics, Ultramint Pro by 8 Teeth. And I believe this is a scaling tip, but it works perfectly in these cases. It's a ultrasonic scaler tip, model P as in Paul, 3-S as in Sam, just in case you're wondering. And I'm carefully and slowly removing the dentin over these calcified canals. And let's see if we get something. My assistant is one assistant. My assistant to the left is suctioning, so the green suction is my assistant to the left. My assistant to the right, blowing air into the tooth and also on my mirror, just to get rid of the breeze so we can see better. See, very slowly, I'm taking my time. Oh, did you see that? A big piece of pulp stone just popped right out. Huge piece popped right out. Just taking my time, not being aggressive. Remember, going through a crown, the canal orifices, they're not where you think they are. If you're going by the anatomy of the crown. So you kind of need to know where to look for these canals, especially if you have a calcified case like this one. So I'm taking my time, very slowly, just removing the dentin, reading the geography of the dentin, the discoloration, the changes in color of the dentin and what have you. Now I'm using my Endo Explorer to see if I get a stick, to see if I get anything that would resemble a canal orifice. Perhaps something right there on the distal buccal. Looks like I got a little something, little catch right there. All I need to do is, all I need is just one canal. Once I find one canal, then I use geometry and I can find the rest. So it looks like the distal buccal is what I'm going for right now. That looked promising. So as I said, if I find distal buccal, then I can find distal lingual, then I can find mesiobuccal from the distal buccal, and then mesiolingual from the distal lingual. These cases are tough. They ain't easy. So all right. So I'm trying to see if I get a catch somewhere. That's a 08C file, brand new 08C file. I'm trying to see if I got something. I had to bend it a little bit, curve it, and see if I got something. Looks like I'm trying to see if I got something on the distal. If I get a catch. Yeah, I did. There you go. There he goes. Yep. I found one of the distals. It looks like a perhaps distal buccal canal that I was able to locate. Yep. There it is. All right. Very good. So we found one of the canals. Looks like the distal buccal canal. Excellent. See if we found something on the mesial. Seems like a little catch there. Yep, but you can see the distal buccal that we found. All right. Okay, so now I switched my ultrasonic tip to a thinner one, and I want to trough that mesial area there a little bit more. Let's see if this tip is helpful. As you can see, again, no rush. I'm just taking my time. When you rush, bad things happen. Everything is done under a surgical operating microscope. Rubber dam is on. Patient is comfortable. All right, let's see if we got something on the mesial. I got a, kind of looks like a little white dot. Let's see if that's anything. Again, that's a C file, 08 C file. Come on. Nope. I think I'm gonna need to trough a little bit more to remove a little bit more dentin. All right. So now I'm switching to a very thin end cutting diamond burr. Again, under a surgical operating microscope. Direct vision. I'm not doing it blindly. And I'm troughing a little bit more. Those ultrasonic tips, they were not very helpful. All right, let's see if I can put an 8 again in the mesial. No. Once the tip bends, man, forget it. What the heck is this? Is this something? Take a look. Remember, my goal is to remove as little dentin as possible. You know, otherwise I can be very aggressive, go in there and I want to maintain as much of the tooth's dentin as possible. All right, back with my ultrasonic tip. Let's work on the distal a little bit more. Sometimes that's what I do, you know, when I don't get any progress on one area, I move to another area and try to progress in the other area. And then just move back to the area that I wasn't getting much progress. Because it can get kind of frustrating when you're just working on one area and you're not advancing. You feel like you're not moving forward. You're not accomplishing anything. So just move to another area. So again, I'm working on the mesial right now here and just troughing along that mesial wall where I believe the canal orifices are. Six-handed dentistry. One assistant is suctioning, the other assistant is blowing air on my mirror and inside of the tooth to get rid of the debris. 6-handed endodontics. All right, Endo Explorer, poking around to see if I feel a catch. Sometimes with the Endo Explorer, I can just poke right through the calcification and right into the canal. All right, so let's go ahead and clean the tooth with 6% hypo and see what we can see. All right, so let's see. This is a 10C file, okay? And I believe I found one of the mesial canals, because that's what it looks like. It looks like I'm inside a mesial canal. My 10C file is attached to my M4 safety handpiece, which is a reciprocating handpiece, and I run it at 1000 RPM, torque off. It not only instruments and shapes, it also activates the 6% hypo sonically. That's the great thing about the reciprocating handpiece, especially when you run it at 1000 RPM. I strongly recommend that you just don't go and buy a reciprocating handpiece and put a file in it, and stainless steel K file or a C file or what have you in it, and start working on a patient. Don't do that, please. You're gonna break a file. You definitely need to practice on many tens and tens of extracted teeth before you start working on a patient with it. Yep, looks like I found the mesiobuccal canal and I found the distal buccal canal. Of course, I'd found the distal buccal canal before, and it looks like I found the mesiobuccal canal as well. All right, so what I want to do is, I just want to get a working length. Let's see what the mesiobuccal working length is. And I'm using the Finepex apex locator by 8 Teeth. It's a pretty good apex locator. I use it all the time. Right there. It looks like it's about 21 millimeters. Yeah, that's what it looks like. $21. All right, let's see what the distal buccal is. You can see that I watch wind the number 10 C file. It's a 25 millimeter C file. And I'm watch winding it slowly. Remember, there is hypo in the canals, but the pulp chamber is dry. When I'm using the apex locator, that's what you need, a little bit of hypo in the canals, but the pulp chamber has to be dry. All right, looks like this buccal is also 21. So we found the mesiobuccal and distal buccal. And now the rest is pretty straightforward. Now from those canals, location of those canals, I can go ahead and find the other two canals. Again, irrigating with 6% hypo. Also, when you put hypo in the canal, the liquid itself acts as magnification. Have you noticed that? All right, so I got a 10 now, 10C file attached to my reciprocating handpiece. Now that I know the exact working lengths of the two canals that I found, so I can, and look how I'm using the 10 file. Up and down, brushing motion, away from the bifurcation, danger zone. You see that? And I'm also activating the 6% hypo. All right, here we go. This to buckle. (1,000 RPM torque off). (10C file attached to my reciprocating handpiece that runs at 1,000 RPM torque off, instrumenting and also sonically activating the 6% hypo. Up and down, agitating the hypo, as you can see. Patient said he was feeling it a little bit. So immediately, I didn't dismiss the patient. I didn't say, oh, what are you talking about? What have you? Nope. Right away, PDL injection. I'm administering PDL injections right now. And I'm using Septocaine. There's Septocaine in that pen. There you go. You find the sweet spot right inside of the PDL and inject, and patient should be fine. Make sure that your patient is comfortable when you're doing a root canal. Don't let your patient suffer. As soon as the patient says they're feeling something, don't dismiss the patient or ignore the patient. All right? Immediately address it. You want your patient to be comfortable. I mean, as comfortable as possible. I mean, how comfortable can someone be with the rubber dam on and, all that stuff? But you want to make sure that they're very comfortable. I always tell my patients, listen, you're not at Disneyland here. You're getting a root canal. I'm going to ensure that you're comfortable, but don't think that you're here in Disneyland here. It's going to be uncomfortable a little bit at times, but I'll do my best to make sure that you're comfortable. Sometimes you need to tell your patients that, so that they know that there's a little bit of uncomfortableness. I mean, it's not 100%. You have to tolerate the rubber dam. You may have a hard time, swallowing, and things like that, right? But pain, I don't want the patient to suffer. As soon as they say they can feel it, I make sure that they don't. I administer the proper local anesthetic. All right, I'm going to a number 12 now, number 12 C file. Again, pay attention to how I'm using these C files, these stainless steel C files in my reciprocating handpiece in a brushing motion, up and down, brushing motion away from the furcation. Not only instrumenting and shaping the canals, also activating sonically the 6% hypo. Right now, I'm creating glide paths in those canals that I was able to locate. I want to make sure that I have a smooth, predictable, and reproducible glide path. Number 15, C file. Again, pay attention to how I'm using these files and also the reciprocating handpiece. It may look easy. I may make it look easy, but it's not. So I strongly recommend that you practice on tens and tens of extracted teeth before you start using this technique on your patients. Up and down, brushing motion. All right, I'm using a number 20 flare file now. There you go. My flare file, I'm not pushing it. Remember, it's a 5% taper, this flare file, and I'm just using it in a brushing motion. I'm not forcing it because it's a thicker file and has has more taper than a number 10, number 12, number 15, which have 2% taper. This has a 5% taper, so you really want to be careful with it. You push it, you can break it inside of the canal. This tobacco, again, I'm using it in a brushing motion. I'm not forcing it. Very good, yeah. Very nice. Creating a smooth, predictable, and reproducible glide path. All right, let's go ahead and irrigate with 6% hypo, yellow needle now. Now I can go deeper into the canal and irrigate with the 6% hypo. Copious amounts of 6% hypo. That's a irrigation needle, so it's a side venting irrigation needle. Make sure you use a side venting irrigation needle. A little bit of air to dry and to inspect to see what we got. All right, so this is what we have so far. That's distal buccal canal right there. And we got the mesiobuccal canal. Also, almost fully instrumented to working length, both of them. All right, so now we need to look for the distal lingual. So as you can see, I'm troughing. Again, I thought I got it. I asked my assistant to give me a file on the reciprocating handpiece, and it looks like I got the distal lingual canal. That was very close to, actually very close to the distal buccal canal. Let's go ahead and irrigate with 6% hypo. All right, number 15, C file. To working length. Up and down and brushing motion away from the furcation towards the distal buccal line angle and distal. Irrigate again with 6% hypo. All right, let's dry and inspect. I'm just using my Endo Explorer right now to see if I can get a catch. All right, let's go ahead and use our ultrasonic tip, ultrasonic device, and trough some more. All right, so let's take a look. Let's see what we got. Number 10, C file. And is that something? Actually, it's an 08 C file. I apologize. Yes, We found it. And I had my assistant put a little bit of hypo, fill the pulp chamber with 6% hypo. And here it is. We located the other mesial canal. After much controlled troughing. Pretty calcified, as you can see. But I'm just taking my time with the 08C file attached to my reciprocating handpiece that I'm running at 1000 RPM, torque off. Pulp chamber and canals are filled with 6% hypo. Up and down, slowly, brushing motion away from the furcation. Just agitating the hypo, trying to get to my working length. It's very likely the working length on this one is also 21 millimeters. And from the angulation of the 08C file, it seems like they join. The two mesials join. Up and down, up and down. There you go. Up and down. Activate the 6% hyposonically, as well as instrumenting the canals. Very nice. All right, let's go ahead and irrigate copiously with 6% hypo again. All right, here it is. I had to dig really deep to hit it, to catch it. Number 10C file now. There you go. Perfect. All right. It's going to be quick now. Once you locate them, it's going to be quick now. Let's inspect. You can see how close they were. And then the two distals. As I said, the canals are not where you think they are when you have a crown on a tooth. The canal orifices are not where you think they are if you go based on the anatomy of the crown that's on the tooth. So if you're not experienced, don't do it, or remove the crown. Just cut the crown off. Unfortunately, if you cut the crown off, that means the patient would have to pay for another crown. That's why experience pays off. Not only it pays off for the patient, because this root canal that could have taken a dentist maybe multiple appointments or maybe 3 hours to do, I did it in about an hour. Also, I saved the patient tons of money because this patient won't have to get a new crown. See what I mean? So less time in the dental chair, less visits, and no need for a new crown. The patient doesn't have to pay for a new crown. So worked out for the patient. So your experience, the more experienced you are, the better off your patient is. More beneficial to your patient. Number 15 now. Very good. Mesiobuccal, mesiolingual, distobuccal, distolingual. And it looks like both mesials and distals both join. So mesiobuccal and mesiolingual joins. Distobuccal and distolingual joins. They join each other apically. All right. Again, copious irrigation with 6% hypo. All right. Let's go ahead and go in there with our number 20 flare file. Again, very carefully. I'm not forcing it. I'm not pushing it. I'm not forcing it. I don't put too much force, apical force on it. Just try to shape and taper and instrument the canals as far as it wants to go. Brushing motion up and down away from furcation towards the proper appropriate line angles of the tooth. My assistant constantly ensures that there's no hypo around the tooth, collecting around the tooth, pulling around the tooth. See, once you locate the canals, the rest is pretty straightforward, at least for me. Locating these canals is tough because, as I said, there was no pulp chamber and the canals were pretty calcified. All right, going back in with 6% hypo. Pay attention to how I use the hypo also. Up and down, up and down. I don't let it bind. I don't let the needle bind to canal walls. All right. Excellent. Very good. All right. So here it is. Super Flexi Gold. These files are amazing. I love these files. Super Flexi Gold. These files. You can purchase them from flexivodental.com. Flexivodental.com. They're great. You really have to try hard to break them. But again, remember, you need to have a good glide path. All right, so next file in the series. Distobuccal. Then we go to distolingual. Perfecto. Irrigate. Again, 6% hypo. Yeah, these files, Super Flexi Gold and Easy Shaper files, they're pretty good, and you can purchase them from flexivodental.com. I make no money off of these files, by the way. So I have no financial incentive. All right, let's go ahead and custom make our master gutta percha cones. I'm using just a regular number 20 I believe these are 4%. Up and down, up and down. Again, also activating the 6% hypo this way. If it's long, I cut it so it matches the length of each canal. I cut the apical portion of it. So I put it in, up and down, measure it to my reference point, and if it's long, whatever the number is, I cut the tip of the gutta-percha cone. There you go. Up and down a little bit. Activate, measure, custom, fabricate your own gutta-percha cones. All right, we got it. So this is our final irrigation. I use 70% isopropyl alcohol. So this is 70% isopropyl alcohol. All right, microsuction. And take a look. I evacuated one canal and I got evacuation from the other canal as well. Mesial, and same thing with the distals. Suctioning the isopropyl alcohol from one also caused loss of volume in the other canal. That means that the canals join. A little bit of air. And that's what we have. 2 mesials and 2 distal canals. Let's go ahead and dry the canals further with sterile paper points. And this is another way to confirm that the canals join. See, I put one in and the other one really doesn't want to go all the way to length. Distals, same, distal buccal, distal lingual. Take a look, see, doesn't want to go in. That means that they join. The canals are nice and dry. I buy these sterile paper points. I don't sterilize them in autoclave or something. I just buy them. They come in packs of already sterilized paper points. And I buy them that way. All right. So AH plus sealer. I dipped the gutta-percha cone in AH plus sealer. That's seated in the canal. Next one. Mesiolingual goes in. Very good, just like that. Excellent. All right. System B to remove the coronal half of the gutta-percha and thermal plasticize the remainder. Apical force on the Buchanan number 2 plugger to condense the gutta-percha. Very nice. Let's do the same with the distals. Distal buccal goes in. Perfect. Distal lingual. Excellent. System B, heating unit to remove the coronal part of the gutta percha and thermoplasticize the rest. Number 2, Buchanan plugger. Apply apical pressure. Hold for a few seconds. Excellent. All right. Obtura gun to fill the rest of the canal or canals. Thermoplasticized gutta percha goes in. Obtura 3 Max. This is the unit that I have, name of the unit. All right, so that's it. Again, use number, here I'm using, looks like number 3. Yeah, number 3 Buchanan plugger. And further condensing the gutta percha. And this video turned out to be kind of long, so let me, let's just go ahead and look at the final result. What I'm going to do next is I'm going to use isopropyl alcohol cotton pellet and clean the pulp chamber and walls, and a sterile sponge goes in, cavet goes in. That's how I temporize the tooth and remove the rubber dam, clean the patient up, and take a couple of radiographs, multiple angulation, and patient is done. Refer the patient back to his dentist for the permanent buildup. As you can see, the crown is fine. Let's go ahead and take a look at the post-op. So remember, this is what we started with. And here's the post-op. 2 mesial canals, 2 distal canals. And this gap, there's always a couple of people who ask me what this is. This is just the sponge that I put in and cavet over the top. This is one angulation. As you can see, everything went beautifully. Beautiful shaping of the canals. Beautiful taper. Kept the apical diameter as small as possible. This is another angulation. Again, you can see the 2 mesial canals that join apically, 2 distal canals that join apically, and look at all of that anastomosis between the distal canals. All right, so everything, as you can see, went beautifully. We temporized the tooth. Patient is going back to his dentist for the permanent restoration. This is how it's done. I hope you find these videos to be useful. Please make sure you've subscribed and comment and like the videos, and I will see you next time in the next video. Bye, take care.